we'll just go to our next case, which is about CTO PCI, and it's being presented by Dr. Wasim Ashraf and Dr. Shahjahan. Please, Dr. Shahjahan.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Mohammad DrMSMirza, currently working as Senior Registrar in Chaudhry Pervez Institute of Cardiology. And Dr. Wasim Ashraf, who is Assistant Professor of Cardiology, will accompany me in this presentation, which is percutaneous treatment of a CTO in an anomalous RCA. So basically, this is a case presentation of 57-year-old male who is diabetic and hypertensive. He had an episode of inferior wall MI 7 years back, for which he was not being thrombolized at that time due to late presentation. Now he presented in a private hospital for evaluation of long-standing history of class 2-3 angina. His echocardiogram was done, which showed hypokinetic basal and mid segments of inferior and lateral wall with ejection fraction of 45%. And his baseline coronary angiogram was done through right radial approach, which showed normal bifurcating left main stem originating from the left sinus. And CIRC is a codominant vessel with mild irregularities, and OM2 shows only moderate disease in the proximal segments. LAD exhibit no significant stenosis, only mild irregularities throughout of its course. And here in this allocranial view, center of 3 collaterals can be visualized arising from the left system toward the RCA. JR4 diagnostic catheter was taken to engage the RCA, but they could not succeed. A non-selective view in the left cusp, which showed faint feeling of anomalous RCA from the left sinus. So they switched to XP3 guider, and here we can see a codominant RCA with total mid-occlusion, and distal vessel fills retrogradely from the left collaterals. So they advise patient to go for percutaneous intervention of this RCA, and patient presented in our institute for further workup. Considering the guidelines, initially AL1 guider was taken to engage the right anomalous RCA, but we could not succeed. So we switched to XB 3.5 guider, and here is a selective engagement of RCA. The lesion was crossed with 0.014 non-tapered polymeric guide wire with a balloon support of 1.25 into 10. Lesion was pre-dilated with semi-compliant balloon of 2 into 15 at 18 atmospheric pressure multiple times for the better preparation of the lesion. Was stented with 3 into 38 everolimus eluting platinum chromium stent at 20 atmospheric pressure, and the stent was post-dilated with 3.5 into 15 non-compliant balloon at 18 atmospheric pressure multiple times. So you can see the pre-procedure RCA, and these are the final results. Final check injection did not show any significant disease, and there is TIMI3 flow in the distal vessel. So going through the literature, aortic root can be divided into right and left sinus of Valsalva, as well as into the ascending aorta with the help of imaginary lines. And this diagram, it represents different possibilities of anomalous RCA origin, and mainly there are 5 possibilities which we label as A, B, C, D, and E depending upon the location of their origin. Location A, it is adjacent, and location B, it is inferior to the left main stem, as we can see here. Location C is also from the left cusp, but it is toward the commissure. Location D is above the sinotubular plane. Location E is from the right sinus, but it is leftward and superior origin. And F location, as we all know, it is the normal origin of the RCA. Actually, acute angle in between the anomalous RCA and aorta, it creates a slit-like orifice, which may prevent the selective engagement, coaxial alignment, and better guiding support. And we all know that these 3 parameters are very important for a successful intervention. So that's why for interventionist, it is very important to know about different possibilities of anomalous coronary's origin, so that they can decide a better catheter for their diagnostic as well as therapeutic purposes. So let's discuss about different guider options depending upon their location, starting from the location A, which I already have told that adjacent to the left main stem. 2 best catheters with special 3D shapes for selective engagement. The first one is LIA left coronary Emplart's catheter, either it is in 45 degree or 90 degree. In this diagram, they engage this with LIA left coronary Emplart's 90 degree catheter. For location A, the other option is RACAOS, launcher coronary guider catheter. And as I already have told, that location A ostium is adjacent to the left main stem. So extra care should be taken to mitigate the risk of dissection. Now we'll talk about anomalous RCA, which is not adjacent to the left main stem. These are location B, C, and D. BC from left sinus, already we have discussed, and D is above the sinotubular plane. For B and C, AR 1, 2, 3 guiders are the good option. And for D, which is the origin above the sinotubular plane, engagement approach is similar to the SVG, as we use JR4 hockey stick and multi-purpose guider in SVG, but there are some other options also available like AL, AR, and 3D RCA. Anomalous RCA from the right cusp, which is location E, so might be difficult to achieve selective engagement and support in this 3D RC implants left and right guider. Extra support is needed. Sherpa NX balance is a better option. Now, some words approaching a CTO, we have to go through the 4 parameters. The first one is proximal cap. We have to look for either it is ambiguous or not. If it is not, then we have to look for whether proximal cap is blunt or tapering, and is there any presence of a side branch near the proximal cap. Then we have to look for the lesion length, whether it is more than 20 mm or not, whether the lesion is calcified or tortuous. And the third thing is to look for the distal cap. Either it is at or near the bifurcation, and we also have to look for the distal vessel caliber, either it is more than 2 mm or less than that. And the finally, last thing is to look for is collaterals, either these are epicardial or septal. This is very well known hybrid CTO crossing algorithm. First thing is to go for dual injection. Then we have to look for these 3 parameters: ambiguous proximal cap, poor distal targets, and appropriate interventional collaterals. If these are not present, antegrade approach should be opted. If these are present, then we can go retrogradely. If we opted for antegrade approach, we should know about the lesion length. If it is less than 20, we can start with antegrade wiring. But if it is not, then antegrade dissection and re-entry either with Stingray or last technique can be opted. If we opted retrograde approach, then true lumen puncture or dissection and re-entry are to be start with. After going through the literature, we have come to know that different institute, after performing the anomalous RCA stenting, they also advise their patient to go for CT coronary angiogram. We also did the same. And here is the report that aberrant origin from the left coronary cusp with interarterial course, that is the malignant one. So our patient had malignant course. Here arises a question. A patient having anomalous origin with a malignant course, as in our patient, of RCA with significant disease, what treatment approach is a better option? Either it is percutaneous or surgical correction. So this was the main thing which I wanted to discuss over here. So we went through a ANACOR French working group of anomalous coronary arteries. They standardized an algorithm for patient with anomalous origin of RCA. If patient had aborted sudden cardiac arrest, you have to go for surgical correction with ICD discussion. But if it is not, then we have to look for either patient is having ischemic symptoms or documented ischemia. If yes, then only surgical correction will be advised if patient age is less than 30 and patient is involved in professional athletic activities. If it is not, then interventional correction can be offered in all other cases. But if patient is not having ischemic symptom, we have to look for high risk anatomy, as we have seen in our patient, malignant course. If that is also not present, then no correction, only clinical follow-up and exercise restriction. If patient is having malignant course, then case by case discussion, but correction by surgery will be only offered in those who are involved in professional athletic activities. So in conclusion, only 2 things. PCI may provide an interesting alternative in selected adult population with age more than 30. Stenting of an interarterial course is feasible and safe without risk of aortic and coronary dissection. And the last thing is arterial remodeling with an increase in lumen area can explain myocardial ischemia resolution. Thank you.
Welcome, Professor Nadeem Rizvi. Thank you very much, sir, for coming. So is there any comments from the panelists, and if there are any questions? Nadeem sir, Professor Nadeem sir, if you would like to say a few words about it.
Yeah, thank you very much. I'm sorry I joined a little bit late. I had an interview somewhere. But this is an excellent initiative, and I think this was an excellent talk. आपने बड़े clearly ये जो ABCDEF है उनको बता दिया। और मेरा ख्याल है कि इससे ये हमारे पास ये जो इन्वेंट्री आपने कही है 3D के अलावा, वो तो सबको मौजूद होती है। मेरी सजेशन यही है कि आप इंटरवेंशनल केसेस से पहले ही जो एनामलस जब भी कोई आए तो उसके ऊपर ज़रूर फेलोज को ट्रेन करें कि दे शुड बी एबल टू हैंडल AL एंड AR एंड अदर शेप कैथेटर्स rather than कि उनको एक इमरजेंसी में कभी करना पड़े। But I think that was a very good presentation.
Thank you, sir. Thank you.
Thank you, Dr. Shahjahan.